So, we view our credentials as we've served the residents and visitors of the county for more than 100 years. We've been your partner in healthcare through that period, and for decades we've been active partners with both Big Sky and West Yellowstone physicians and providers in mutual service to patients. In response to particularly Big Sky in 2004, the need for a pharmacy, we opened the Big Sky Pharmacy to really provide local access to pharmacy services to the community. And like our colleagues at Billings, we've received numerous national awards in quality, safety, cost efficiency, and patient experience. Actually, Healthgrades just gave us the 2013 Patient Experience Award, top hospital patient experience award. We're very proud of that as an organization. Also, Bozeman-Deaconess has consistently been ranked as one of the top community health systems in Montana, the region, and the nation. I guess the great component of this is we have two very high-quality health systems that are really committed and looking to be a partner with you. I think in the other part, in talking about quality, really, here's some rewards and recognitions, some of our list of recognitions of our commitment to our patients. Again, that information can be available as you go through and look at the presentations. But also on the quality performance side, they're actually the CMS website, which is our hospital compare. As a hospital, we're all required to report 47 measures to the CMS. And so if we look at those measures, I think what we want to do is, simply reiterate the quality of the two systems you're talking about. Currently, and literally this information was pulled off yesterday, of the 47, Bozeman-Deaconess had a higher score than our colleagues across the state and Billings. They were better on 11 of them, 13 of them, we were the same, basically. But the reality was we're talking about 0.1% difference on these scores. And again, so reiterating, clearly we have some tremendous high quality, high safety, patient experience, committed organizations within Montana. We're pleased to be one. We're pleased to be in partnership with Billings Clinic and that level of recognition and accomplishment. We've also received the consumer reports. We ranked second in Montana. This was in the 2012 ranking. Leapfrog, we've had A ratings both spring and fall for, actually we're only two hospitals in the state of Montana with A ratings. And then for value-based purchasing, we had the highest score. Again, this is a CMS measure. The highest score of any general hospital in the state of Montana for first quarter of fiscal year 2013. That information literally came out a few weeks ago. And then for readmission, another thing that looks at how well we are managing those patients with chronic conditions that have a high incident of readmission. We look at that as we're being looked to judge and actually penalized if we don't do a very good job based on the reimbursement we get from Medicare. The great news is neither Bozeman-Deaconess or Billings Clinic, our performance was above national averages, and so we didn't receive a penalty associated with the readmission that we could have. So again, I think it reiterates the quality of health services here in Montana and those available to you not only in Big Sky, West Yellowstone, but really across central and eastern Montana. So with that, close our presentation. Again, there's the website where you can get this presentation as well as the questions and answers from that's provided back to the committee. And with that, we'd like to open it up to questions. Yes. Give me just 1 second because we're going to have to.
West Yellowstone, and I want to talk to something, and then I want to ask you a couple questions. So my first one, on your slide about the level of existing care in West Yellowstone, I can tell you for the last 2 years I've tried to get an x-ray, and the equipment's outdated, or it's broken, or there's not a technician there to do it. And the other problem I have comes with, and I don't know all the medical terms for acute care, but we had a young boy having a leg, severe lacerations. They cannot stitch. So CHP can't, so we had to transport him to Ennis. So when I look at the next slide that says step 1, secure financing, and then step 2, before you'll even provide temporary physician care, I'm wondering, why can't you do those simultaneously? Why can't you make the same commitment to West Yellowstone that you're willing to put out to Big Sky? question is, what about the technology? What about the equipment in the CHP offices that isn't working?
Well, I can't address CHP, they're not part of our organization, but at the same time, if there aren't technology, we'll go back and talk to Landers and DeBuck, the two leaders of that organization, and find out what those issues are. As it relates to the recruitment, the reality is those steps do happen simultaneously because the first step really is actually done. The request has been made, and at least the preliminary discussion at the City Council earlier this week was to fund the majority of the request for the next year, the budget year for that. Moving forward, the first step does need to be really looking at temporary or interim or part-time coverage. I think you'll also agree with me that there has been a kind of a very sparse history within West Yellowstone of being able long-term to retain and recruit physicians into the marketplace for a variety of reasons. It's what CMS would call a deep rural site. It has a tremendous variation in population and sustainability of a practice as it goes forward. And so it will take time to recruit a physician to that market, regardless of who's recruiting the physician to the marketplace. And so the interim step is to try to find that part-time coverage from existing, really assisting physician bases within our organizations to do that. And by the way, it may be done with us financially subsidizing that and it being employed through CHP and their physicians, or it can be through really our recruitment efforts or basically rotating physicians as part of that practice. I would agree with you. West Yellowstone needs to be better served than it is as it's gone forward. I would also add to that, I think there needs to continue to be a discussion within West Yellowstone that there's consensus about the direction of healthcare in the community. And because unfortunately there's been itinerant coverage historically, the primary care patterns of the citizens of West Yellowstone have developed long-term relationships in Idaho and in other places within Montana, and redirecting those back to a primary care practice will take time. And that will mean there will need to be a partnership in helping subsidize the practice as it goes forward with that. So I think in a lot of ways we're agreeing. I think it's an approach in the support of that. But I would agree, it's not currently an acute care practice. It has limited capacity, and that's why it needs to change and improve. Well, I appreciate the question, and I certainly understand the earnestness and the frustration of kind of the current scenario there.
Actually ask you the same question that I asked Billings Clinic, and part of my concern is level of commitment on behalf of the institutions. The proposal that Billings Clinic gave us said that $5 million would come from Big Sky, $5 million would come from Billings, and the balance would be debt that would be signed by whatever organization or entity is created to own the critical access facility, and with no personal liability to anybody, but it would be secured by the building. And I was concerned about, how much skin Billings had in the game. I'm going to ask you the same question as it relates to the $21 or $22 million that you're talking about, including loans and liability for loans. What amount would Bozeman Deaconess be on the hook?
I think probably an unknown factor there is what level of philanthropy would be available long-term to offset. But let's just use a similar model. We're anticipating probably a direct cash investment of around 30%. That'd be about $6 to $7 million of the 21. But with 21, 22, it's kind of all the same as it goes. That will come from Bozeman Deaconess Health Services. It'll come out of the cash reserves of our organization. And then the debt, the remaining loan amount, or the remaining amount would go through debt. And as others, we've had initial discussions with the USDA, we've also talked with HUD, we've talked with the Montana Healthcare Financing Administration and those options, and we've also talked to our bond brokers, because we have certainly issued tax-exempt debt in the past, and we currently actually have a couple of projects that are in the planning stages that we may bundle it and simply do it through that. That would be the responsibility of Bozeman Deaconess Health Services. It would be underwritten by the net assets of our organization. We currently have a debt-to-asset ratio of about 15%, meaning we've got $1 in debt for for every $15 in net assets, so very strong financially as an organization. We're talking about taking on here an additional, we'll just say $14 million in debt. So I think certainly well within the debt capacity of our organization and well within the available cash reserves of the organization to make our contributions. Mhm. Yes, sir.
I'm North Yellowstone as well. My question to you is, what level of urgent care do you propose for our community?
One, I'm not sure I can give you an answer of what that is because I think as we look to continue to plan, urgent care, there's two ways in which to handle same-day care. There is integrating it within a primary care practice where you have capacity within your schedule so that you can take walk-ins or same-day types of appointments. The other is to really set it up and run urgent care or walk-in care as a totally separate entity. My experience has been in rural communities, and I've been working in rural healthcare my entire career, that when you're looking at a one or two provider organization, you're going to do it and integrate within the schedule of the organization. Now, that does give you the latitude of running extended hours, in other words, running overlapping schedules at different times when it, certainly you have a higher demand. In the case of West Yellowstone, the influx of your summer months is phenomenal. I mean, it's almost unbelievable from a seasonal variation perspective. That would certainly lend itself that you should have a more extended hours environment during that period of time. And then as you go into your shoulder seasons or your winter season, maybe you're looking at an 8 to 5 operation. But the reality is, this is a rural community. The physicians and providers in those communities are available and accessible, just as Dr. Daniels is here, just as we have physicians in other rural communities, or and Dr. Coyle and Dr. Dunn. So they're going to be available and within reasonable ways in which to handle after hours. I do think it raises probably the key risk of a rural-based primary care practice is burnout. And I think it's been a contributing factor. You've seen not only West Yellowstone in the past, but we've certainly seen it in other communities I've worked with. And these folks can't be on call 24/7, 365. They're not going to stay. And so there does need to be a reasonable expectation of that. But circling back to urgent care, I think it becomes a seasonal discussion, certainly through flexed hours. But really you should, in primary care practices, really integrate that same-day urgent walk-in type thing within a primary care schedule. We do it within primary care practices, even within larger environments like most.
Well, let me rephrase that a little bit. If I fell down and broke my arm, would you be able to help?
Not personally, because I'm not a physician, but so Dr. Walter is probably good, but he's an attorney. I think as you look at the staff in that clinic, if you fell down and broke your arm, I'm not going to be able to answer whether or not they could, because depending on complexity of fracture, it needs to be seen by an orthopod and transferred to a higher center. To assess it and determine whether you need to go elsewhere, yes. If it's a family practice doctor that's in the community and available to help you, yes. Most of those have basic orthopedic training that allow them to fix simple fractures. But the reality of what they're going to do is they're going to fix it, immobilize it, and then they're going to get you a referral to a higher level of care to ensure that you're going to get the right healing, that they were able to clean the break and reset it correctly. But yeah, the answer is family practice, yes. Are you going to see that from a PA and an NP? Maybe with emergency medicine level of training, but not in most environments. And if they're manning an ED and have had additional emergency and trauma training, which a lot of, by the way, rural-based providers have, that you could get at least the preliminary immobilization that would allow you to manage pain as well as then get you to the next level of care.
For West Yellowstone, it doesn't sound like you have much commitment, and also.
I'm sorry, I didn't get the first part of your question.
And it sounds like you don't have much of a commitment to West Yellowstone, and also it's more of a referral base.
I would disagree with your assumption, and I think by working to place and move and really to a full-time primary care physician in the community, that's a significant level of commitment to the community. But again, you can't flip a switch and have someone there. And we need to put it in an environment that provides both professionally challenging and provides balance as it goes forward. So it's going to be a challenge for both whomever the healthcare organization you're working with is and the community to ensure they create an environment that that individual wishes to stay within the community. And I think you guys know the outcome when that doesn't happen. Yes?
In the last few weeks, there's been a lot of stuff going around in this study, and one of the benefits that a lot of people have been talking about going to OCP is the electronic record, communication.
Yep.
Does Bolton Beacons only have one electronic record system that they use?
Actually, no. We have a couple that are integrated and communicate with each other.
Yeah.
And like every electronic medical record system, they are perfect as it goes forward. We utilize in our clinic, we use NextGen, we utilize Meditech in our hospital environment. And within the emergency department, they supplement it with a system called Allscripts. Those are seamlessly integrated to put patient data, patient demographics, and counter information through. But the reality is it may require a physician at times to look into systems, either Meditech or NextGen. And so while we've made great strides in electronic health record, we're not satisfied with the current solution either. In fact, have continued discussions of moving to an integrated environment, like our colleagues at Billings has. Actually, I came from an organization that moved through a couple of systems in that direction. But I guess I would back up and say the current system has continuity of patient information across it. Where the information may initially be entered may be different if it's in an outpatient physician office than if it's in a hospital-based or hospital outpatient-based department. But that information entered in the hospital is available to that doctor in the clinic, just as it would be for the services received here.
Okay, so anything that was recorded here would, under one of the three systems, somehow find its way.
Not somehow find its way, it's integrated technology that will find its way through. It's not a wish and we hope it gets there. Okay.
My second question, if I may. One of the other things that you spoke about last time you did your presentation was the fact that the doctors coming here would be on a rotating basis, which they would need to do, completely understand that. What is,
I'll repeat it if they go ahead. Okay.
just out of curiosity, what is the doctor retention percentage there? I mean, as those ridiculous.
Sure.
How many different physicians over the years? I'm just kind of curious if you're
Sure.
able to have relationships with the same doctor over the years.
No, I think that's a great question. It really talks about what the staffing model going to be within the emergency department, the critical access site here in Big Sky, and then also what is the long-term in our retention. And by the way, the answer to that question is in that online packet because it was one of the questions asked of both organizations by the Health Directions Committee. I'm going to hope I get the percentages right, but I'll be close. But to your first question, yes, as we've looked at that, we view it's important to have board-certified board-certified physicians with emergency training, medicine training. And so the model we're proposing for this market is that we would have individuals who were primarily on rotation here, but probably between 25 and 30% of their time, they would actually rotate through a level 3 trauma center to keep their higher level emergency medicine skills in tune, basically, to get that exposure to them. So you would see very familiar faces. And you may actually see that some familiar face if unfortunately at some point you had to go to a higher level of service in Bozeman. When it comes to retention, our health group is, and again, I think to qualify, about half of our medical staff is employed through our health group, Bozeman Deaconess Health Group. The other half are community physicians. And so I can't speak to their retention or whatever because that's private practice. Within our health group, since we've created in 2005, we've added 52 physicians to the health group. We've had 9 physicians depart. 2 of them are still within the Bozeman community in private practice. 1 of them retired, and the remaining 6 physicians left the market. So if you go through that, it's a couple percentage point turnover rate. So, Other questions tonight? Oh, I'm sorry. Hi.
From the patient's point of view, it has been increasingly difficult to get appointments at Bozeman Deaconess Health Group. Like a year ago, there were 3 pulmonologists. Now there's 1 pulmonologist in the Gallatin Valley, and it's almost impossible to get an appointment. Why are you not replacing the doctors that leave?
I think our colleagues at other organizations would say pulmonology, straight pulmonology is a very difficult recruit. By the way, one of those physicians actually went into hospitalist medicine and runs our hospitalist program. The remaining individual actually left the community and she went back to academic medicine and was one of the individuals that left. From a pulmonology perspective, first of all, keep in mind pulmonary medicine can be managed by internal medicine physicians, as I know Dr. Walter would attest to as we go through. But from a pulmonary specialist, I would agree, it's a critical specialist to continue to recruit. We actually do have candidates coming in and interviewing, but it is an elongated process and one we're as equally frustrated about. It is disappointing from a health professionals as we continue to see evolution of healthcare specialties. Unfortunately, individuals who used to go into pulmonary medicine would also go into what's called critical care medicine, so they'd be the docs in the intensive care units. With the emergence of intensivists and hospitalists, individuals who are dedicated to hospital-based practices of medicine, you're seeing fewer and fewer people going into certain specialties, one of them being pulmonology, because now the intensivist is doing the critical medicine component of it. So it's kind of a declining pool. We certainly would like more of them as it goes through, and I apologize for the frustration that you're dealing with in trying to get an appointment.
Well, the other is the sleep disorders doctor, and you replaced her by a PA.
Actually, no, we replaced her with, we actually shifted the remaining pulmonologist out of critical care medicine.
And he had to give up his internal medicine patients, except he was allowed to keep 10. And my husband and I are among the 10.
I'm glad you made the 10, but by the way, that's news to me, the 10. But tell you what, I'll check on that one for you. But what occurred there was, Dr. Anders basically is trained in pulmonology, critical care medicine, and sleep medicine. A private practice sleep medicine physician left the community, and we had a tremendous interest in wanting to ensure that people had access to that specialty. Dr. Anders then actually discontinued doing his critical care medicine, which by the way was half of his practice before, and now has split his practice half between sleep and half between pulmonology. But the 10 things puzzling to me, and so we're going to do a little checking on that, just to find that one out. And actually to augment that, well, we did add a nurse practitioner to the sleep medicine program. This individual comes to us with almost 10 years of experience working in a sleep medicine center in Butte, in partnership with a board-certified sleep medicine physician. So that is, again, is a continued evolution of healthcare as we look to use advanced practitioners to work in partnership with physicians in specialty areas. But I appreciate your comments, and we have a couple follow-ups to do.
Excuse me, there's time for one more question.
Yes, sir.
Kevin, I'm also from West Yellowstone, and I realize that Big Sky is completely different from West Yellowstone. My question to you is,
Kevin,
I don't know if
You got it.
All right. Kevin, you're proposing to build a facility here in Big Sky at no cost to Big Sky residents. You're proposing in West Yellowstone that it will cost us $200,000 to get a part-time physician. My second question is, we have 1.3 million people come through West Yellowstone every summer and into the winter. We also have about 3.5 million visitors into the park that obviously all go to Old Faithful. You're asking us to complete our service and not to grow our service in a 90-year-old building that is understaffed, and it obviously looks like to me that we would get with the other facility out of Billings, we'd at least get a 3,000 square foot clinic. But we're operating with the same facilities. So I guess basically what I'm saying is you're offering everything to Big Sky and nothing to West that is not going to cost us. And I believe that is right. We're operating off of a CHP, which is federally funded, and you also also know that there's no more money that they can get, so there's no advancement in their service that they can provide to West Yellowstone. So I guess my whole point is, yes, Big Sky, you're getting $21 million worth of facility, and West Yellowstone is paying $200,000 for nothing.
Okay. First of all, there is a federal money out of CHP that goes to West Yellowstone. They're doing that based on the direct operation with it was a $25,000 subsidy, will probably be higher than that next year. Under a federally qualified health center, you can't take the grant money that was sent to devoted to one market, like Bozeman or Belgrade or Livingston, and allocate it to another market through expansion. So it's basically sustaining itself through the help of the city of West Yellowstone. You're correct in that
I'm
regard.
not going to argue with you, but
Yeah.
those funds were delegated before West Yellowstone came into the facility, and they are delegated to Gallatin County, not to just Livingston.
We'll respectfully disagree because, and on that particular fact. But in going forward, I think let's reference back to the study you did as your Yellowstone clinic that showed basically with no new facility, no investment, and I give credit to our colleagues at Billings if they're moving forward to look to make that investment, that a clinic, primary care clinic, a CHP model would require about, with some additional providers, somewhere in the neighborhood of between $100,000 and $200,000 a year to sustain operation. If you add a physician to that, not with an advanced practitioner, that number goes to the mid 200s, if not 300,000. And what you will see, by the way, because if you go and read the answer to the question that was put to us from that, is we're proposing the steps you talked about there, but we also, in our response to West Yellowstone and the committee, said we're willing and open to talk about a risk-share arrangement with the city of West Yellowstone to provide subsidy and support to the primary care clinic. At this time, you're correct. We're not proposing a new facility to the market. And while that's not forever, and the incremental proposal we have made to start with, it is not part of it. It's using the existing city facility, been recently remodeled, and you're right, it's not perfect. But there are not many rural healthcare clinics that are because of the challenges within the market to sustain and build and do capital investment. But again, I encourage you to go out, in fact, you'll see it because you're a member of the committee. You'll see that answer that said, we're willing to go into a risk-share arrangement related to the clinic as well in partnership with the city. And I agree, by the way, I didn't reference that tonight in the presentation. Okay.
Hi, for those of you that don't know me, I'm Mike Scholes. As Jack said earlier, I was co-chairman of our hospital direction committee, but I also want to mention that Lisa Descalowitz is here tonight, executive director of Going in Action. Dr. Jesse Coyle is one of our local physicians, and chief of our fire department is also part of our steering committee. I'd like to speak to the process of our next meeting, which will be in 2 weeks. Here at Bucks T4 again. At that time, we will receive a report from our consultant, Howard Gershon, and then last week if you were here, and he will be talking about the pros and cons of species from both proposals, and he will also be making a recommendation of the way he feels our community should go. After that, the committee which is comprised of between 25 and 30 people. People will have an open discussion. I hope that the hospitals will be here at that time to answer any further questions. And once that is done, the committee will be taking a vote to make a recommendation which they feel is the best direction for Big Sky. Once again, I want to emphasize that it's not a binding recommendation. We're a volunteer committee that has just stepped forward over the last several years of when we got involved with. At different times, we thought it was one hospital, but we have had 2 hospitals that are interested in two very well qualified hospitals, it's going to be a hard decision for everyone, I can guarantee you. And from that, it's not binding, and we would hope that both hospitals will look at our decision and use that for guidance. So that's how our process will work, and I hope that you will all be here. It will not be so much participation from the audience as we've had in the last couple of meetings, but it will be more so be of the committee, but you will get to listen to their own deliberation and see the results, and also see some more questions answered to help us with our decision. If there's any questions from anyone? Yes?
I was wondering who's paying or what is paying consultant?
The consultants paid by the resort tax district, and they were given $20,000 to work through that procedure. Okay.
So who makes the final decision?
Well, as I said,
What
you know,
are the recommendations?
all we can do is that. It's not like we're the city council, and we're not the people that are coming up with the $5 million and such. However, it was apparent that we, through the process, and I'm not going to go into explaining how we have gone between one or two hospitals that were interested in such, but in the end, we had two hospitals interested, and we thought that it would be good for both hospitals to present their proposals, so we would have an understanding of that. I think that they had learned from our community, and I'm sure they probably even learned from each other than such. So, where it will shake out from there, I can't tell you exactly, and I don't think anyone can, but as was mentioned in one of the presentations today, they would respect what the community has to say, and I would hope that be the case with either hospital, but it's very close, I can't tell you. But I think the process was good, but we do not have a form of government that really makes those types of decisions in this community. We have it on a lot of other things, transportation districts, fire department, and all of those things started with similar procedures over the last 40 years I've been here. And, the resort tax itself, it all started with community interest, and quite often sometimes it would go out to a vote. I don't think this community at this time is looking to create taxing authority for the property tax or anything like some communities have. Unless someone else wants to step up and cover that, I don't think that's this committee's decision to go in that direction. So I hope that answers you, but it doesn't really give you, if you want someone to make the decision, then you'll have to find some group that feels they're qualified to make that final decision.
Well, as I'm saying, you guys have graciously put in all this time and all this effort, and, 2 weeks is gonna come down to, and somebody's gotta say, whether it's a vote to the community, I don't know. Somebody's gotta make a decision, because we got two that are ready to move
But I
forward.
do not think anyone has that authority. At least any group that I know that has that authority. We were just trying to help out, give guidance, and that's, we never felt we were ever going to do any more than that.
I appreciate that.
Thank you. You're welcome.
Mike, I think everyone appreciates what you guys are doing and spending a lot of time on this. What difference would it make if there were a city council?
I can't tell you exactly on that, because it all depends, once again, if the city council, takes with authority, comes responsibility, whether the city council does that. It doesn't happen in most communities. It's not that the city councils do it, it's for people to do work. Ours is a little, as, Brett Lodge at least said that they had some different avenues to choose from, how they moved on through it. I'm probably gonna ask Kelly a little more about that, because it's not that, but in the end, it is a volunteer group working with institutions that are interested, and somewhere along the line, that group makes a recommendation, and that's how it goes forward, I believe. Yes?
At one of the earlier meetings, where only Bozeman Lucanis made a presentation, someone from your committee said there would be some effort to take even a straw poll or something to
you that it wasn't part of our process, and I was out of town, so I'm not privy to, that decision by the group that was there. It was never part of, mentioned in our process as such, so I can't speak to that. No further questions. Thank you all for being here, and especially thanks to the hospitals.